Hello everyone, my name's David Atwood and I'm a GP partner at Parfields Medical Group, Associate Medical Director in Livewell and Chair of the Healthy Ageing Programme Board in Plymouth and West Devon. In this short video you'll hear about the crisis that's shared by our older population and the NHS. You will see a tried, tested and brighter future where older people can live longer, better, supported by a flourishing NHS, all told by our patients, staff and the latest data. You'll see how we can make this a reality, and it starts with a national, sustainably funded long-term plan for healthy ageing. This video will explain how, and it's designed to be understood by everyone. So let's begin with a 1-minute biology lesson to set the scene. As we age, our bodies and body functions naturally decline. Fortunately, the human body was built with lots of inbuilt physiological reserve. However, whilst many older people enjoy a natural ageing process and track along the green line where their health does not limit their ability, some show signs of accelerated ageing, with rapid loss of this reserve affecting health and independence. It starts as a slowing up. The weekly shop might take 3 hours instead of 1. As things progress, people may become housebound or in care homes, needing carers for personal care. We have a medical diagnosis that describes this. It's called frailty and it exists on a spectrum, mild, moderate and severe. There's huge overlap with frailty and dementia. Many of us can remember family and friends, both past and present, that have lived with these conditions, and we can also recall a time when they became seriously unwell, needing a hospital admission. Whilst it's true that some medical emergencies are best managed in hospitals, there are also risks. Older people with frailty or dementia have to contend with the illness that brought them in, coupled with the physical inactivity, sleep deprivation, worry and unfamiliarity of their surroundings that comes with a hospital admission. This can accelerate physical and mental decline, and although some people recover, others lose their independence to the extent that they may no longer be able to return home, needing a care home to support them. Let's talk a bit more about frailty in hospital. Half of all hospital beds in the UK will be occupied by people aged 75 or older. Of these, 3 in 4 will have a diagnosis of frailty. For over 75s that are fit and well, the probability of dying during that particular hospital admission is 1 in 50. For those with mild frailty, it rises to 1 in 25. For moderate frailty, it's 1 in 17. For older people with severe frailty, it's 1 in 5. For patients with frailty who do leave the hospital, there's a 1 in 7 chance of being readmitted less than 28 days later. 2 in 5 of over 75s hospitalised will be in their last year of life, of which a quarter will spend more than a month of that precious last year in the hospital bed. The true cost of frailty has never been calculated. What we do know is that the Department of Health and Social Care annual budget is £181.7 billion. We also know that frailty accounts for the following. The true cost of frailty will be many tens, if not hundreds of billions of pounds. And we haven't even calculated the massive personal cost to the individual and their loved ones who are living within all of these statistics. But herein lies a beautiful truth. Although ageing can't be prevented, frailty can be avoided or improved upon if we take the right action. And this action starts with the development of our nationwide long-term plan for healthy ageing. There are 3 components to this entirely achievable, tried and tested plan. Step 1 is identification, and in West Devon we're using the latest technology in primary care IT to do this. And step 2 is to stratify our older population by frailty severity, as outlined in the population health pyramid below. And step 3 is offering evidence-based interventions personalised to the individual. The aim is to prevent frailty and keep people healthier for longer. Staying physically active, eating well, and keeping socially connected are interventions that are proven to work, and our voluntary community and social enterprise, or VCSE sector, has been critical in leading on this work. In addition, our older population with mild frailty have had a bone health assessment to detect osteoporosis and have treatments that keep bones healthy and reduce fractures. People who have developed moderate to severe frailty need a bit of extra support to keep well, and they most benefit from continuity and lifelong proactive case management. To deliver that, teams from across the health, social and VCSE sector have formed up into Ageing Well multidisciplinary teams. This shared team offers lifelong proactive case management using shared IT and shared single assessment called a comprehensive geriatric assessment, or CGA for short. So does this work? Well, let's hear what our patients and staff have to say.
Hayley's part. What can I say? I'm very happy. She's got me on walking to start with. Everything we've asked for, she's done.
I went in and had a hip replacement, and then when they had the operation, they said it's a 12-week recovery, and I went, oh my God. They got us a list of care places to get him in, to get him looked after whilst I was recovering. And it just makes life a lot easier and less stress. Amy's there if I need to talk to somebody about anything, and just reassures you, there's hope on the other end of the phone.
You get to know them really well, you find out what their goals are, and you follow them through on that patient journey and to see them reach their goals. So it's been amazing, I love it.
She's made me part of the effort to cure me instead of just being an onlooker. I have time to say this is worrying me, or this isn't going right, or is this right? I don't want to live in a hospital atmosphere. I want to be in an ordinary atmosphere because I think that helps me.
So the Ageing Well MDT for the Waterside Primary Care Network, which is the one that I work with, is focused on each patient, a holistic general assessment. So I do a physical assessment, I then feed back that information to the multidisciplinary team, which comprises on a weekly basis a 3-hour meeting between community therapy leads, social work leads, GP, community nursing, specialist nurses, the social prescribing services and any other professionals involved with that patient. We discuss, collect and collate that information and create a care plan to support that patient at the end of their life.
It ensures that all of the care workers wrapped around them are actually wrapped around them. I think it's really exciting. Certainly something we hear of a very strong team ethic in Oakside, and it's very much based on a large team of independent practitioners all working together as a sort of flat tier system really, and I think this again allows that across a wider system.
To make life less arduous towards the end of somebody's life, well, what more of a gift can you have as part of your job? To go to work and achieve that, it's pretty special.
So you've seen life through the eyes of our older population and our teams. Now let's look at the locality through the lens of population health. The graph on the left shows that in the last 5 years there's been a 19% growth in people aged 75 years or older, which is important for reasons outlined earlier. However, data from one of our PCNs suggests that the growth is largely driven by people who are fit and well or have mild frailty, where there's been a 4.4% increase, meaning that our population is ageing healthily, living better and enjoying maximum quality of life. In addition to living better, older people may be living longer as a result of this new way of working. This graph looks at survival in 429 patients in care homes who were followed up for 2 years. Patients on the red line received proactive care with lifelong case management and CGA, whereas the group in blue received routine NHS care. These patients were prioritised for proactive care based on clinical need, and they saw a 37.8% absolute survival advantage. Lifelong continuity in case management also reduces healthcare utilisation. By keeping people well, they're less likely to need a hospital admission, with data in our locality showing a 40% reduction in care home admissions across all primary care networks. However, despite additional government investment in hospital-based care, length of stay has increased, which, as we know, is bad news for older people with frailty or dementia. This is a national phenomenon noted by the Health Foundation in June this year. Why is this happening? The simple answer is hospital overcrowding. Now, some causes of overcrowding, such as COVID, are unmodifiable. However, we can modify the flow of patients into and out of a hospital. The situation is analogous to a bathtub with the tap on and the plug left in. The way to modify the situation is to either turn the tap off, reducing the number of admissions, or to pull out the plug, facilitating discharge. We know that proactive care can reduce admissions, but when older people with frailty become more unwell, we also need better urgent care to offer alternatives to hospital admission and support discharge, minimising the time spent in hospital. Urgent care teams should be structured as follows. When an older person is in crisis, an early and day medical evaluation should take place by an urgent visiting service, where at the end there can only be 4 outcomes. Green, the patient does not need urgent care and can be discharged to primary care. Yellow, the patient needs urgent care, but this can be managed in the community. This is done by intermediate care, which is an urgent MDT that prevents hospitalisation and supports early discharge. Some of you may have also heard of virtual wards, and these are best imagined as high-end intermediate care for more complex patients and needing more intense support. Sometimes patients require hospital teams for their care, and one really useful option is called same-day emergency care, or SDEC. It's best imagined as an emergency pit stop to get some urgent testing, specialist support and treatment before being discharged same day to intermediate care. The last outcome are patients in the red group who have an acute emergency needing a standard hospital admission and can be discharged and supported by intermediate care teams as soon as it's safe to do so. And again, these are shared teams on shared IT, delivering a shared single assessment based on CGA. Currently, most of the NHS recovery plans focus on investing in hospitals. However, we've seen that the solution is not more hospital beds. The solution is to resource the community where the biggest gains are to be had. We've seen the benefits of proactive care. We also need to resource the urgent care teams marked in green and ensure that they have the enablers that they need to maximise continuity and quality of life. So let's see how this all fits together. Imagine taking a helicopter ride to the skies above your locality in the UK and looking down. You'd see different communities, all based around the GP surgeries operating within a primary care network footprint. GP surgeries working together with community services, VCSE and adult social care would focus on keeping people healthy, socially included, identifying and preventing frailty. For older people with significant frailty, on top of each PCN is an Ageing Well MDT, which coordinates your proactive care with shared teams, shared assessments and shared IT. For urgent care needs, PCNs will make one phone call to the urgent visiting service, which is part of the PCN's aligned intermediate care team. The patient is managed until the crisis is stabilised, tapping into SDEC and virtual wards as needed. With the support of health, social and VCSE, the aim will be to keep older people with frailty in the community unless they're having a medical emergency, which can only be managed with hospital-based care. Once the situation is stabilised, PCN-aligned intermediate care teams can support discharge back to the community. This hub-based model built around the community of a primary care network, has been structured in a way that maximises continuity with shared teams, shared IT and a shared single assessment. We now stand at a crossroads. We can keep doing more of the same, but the statistics on frailty speak for themselves. Or we could move away from the bed-based model of care and choose a new path. We could develop a national long-term healthy ageing plan with a focus on community-based working and realise the huge win for better patient satisfaction, staff satisfaction, population health and healthcare utilisation. We have seen the stories, we have seen the data, and this is within our grasp. And lastly, there's a moral imperative to do this. To quote Hubert Humphrey, the way we treat our children in the dawn of their lives and the way we treat our elderly in the twilight of their lives is the measure of the quality of a nation. Thanks for listening.